My name is Dr. Aly-Khan Lalani. I'm a GU medical oncologist at McMaster University and the Jurevitsky Cancer Center in Canada. Recruitment is moving along very nicely. It's a highly anticipated study. We have sites open across multiple centers in Canada and Australia. We have passed halfway through recruitment already, and so we're looking to be full steam ahead into 2024. We're just having so many pieces of data showing that potentially non-invasive treatment to a primary kidney mass, like radiation of some form, whether it's in a primary definitive treatment for folks who can't undergo surgery or it's not required, or in a metastatic setting where it's to leverage so-called immune response. I think we're all quite excited to see what the composite of this data does. Our trial is a randomized phase 2, so we'll have an active control arm, but all the pieces are coming together that we're adding to it. And I think the real takeaway for the viewer would be that RCC is becoming multidisciplinary in so many different ways. Surgeons are still heavily involved. We have adjuvant data, where we have data looking at radiation in our setting, in a stage 4 setting. So there's so many players at the table to optimize care for our patients. So we're quite encouraged with it so far. So our CYTOSHRINK trial is including patients who have the primary kidney in situ, allowing up to 20 centimeters of a primary renal mass, and where cytoreductive surgery is deferred or not really recommended for them. So that's, I think, quite a good range of de novo patients that could be included. I think the other areas of SBRT, like metastasis-directed therapy, these are patients where I think all should be encouraged to be on a trial protocol, but for example, in an oligo-recurrent or oligo-progressive setting, these patients might do quite well where it's, let's say, 1 to 3 lesions, not needing a change or new systemic therapy, and otherwise clinically well. So I do think that's the kind of profile for metastasis-directed therapy. Our trial is looking more at the primary in a stage 4 setting. So the CYTOSHRINK trial will be looking at the long-term follow-up and safety of patients who got treatment to the primary kidney mass in a stage 4 setting. So toxicity profile will be a little bit potentially different in light of the remaining burden of their disease. But in terms of metastasis-directed therapy, I think these patients are doing quite well. It obviously depends where the site is. Is this a large primary lung mass as a metastasis-directed therapy? Is this in the bone, which would have been causing significant amount of pain? But I think the information we have around the world for RCC, that these patients with SBRT at unique dosing of fractions and overall gray delivered can tolerate this treatment quite well. And I think importantly shows that we have such a great multidisciplinary component of managing RCC.